Okay, so this is our fifth and hopefully not final course in a series on Chrome Guided Smile. I always like to start off with this screen. It's a partnership with Chorus 3D in Ireland and Road Dental Lab in Cleveland, Ohio, and James and company are providing European support, European product, all the periphery items that come with Chrome and Chrome itself. For all these surgeries they're doing. They're a wonderful partner. And in this series, this is I believe this is number 5. This is going to be more of the preliminary workup, patient analysis, smile analysis, some of the things that are so important to start a Chrome case. And I know I've mentioned it during the records program, the very first one, but just as an example, if we get, if 10 cases come in today, at least 7 of them, even after all, after these few years of making them, and even with some of our most experienced Chrome doctors, at least 7 of them stop for a more serious evaluation about opening up the bite, about sometimes just about basic records that came in, about some smile analysis and vertical dimension, and all kinds of questions come up. So only 3 out of 10 would just simply go to the pipeline. And Joe works with a small team. It's him, a dentist, and then just one other CDT who help James. James does a lot of evaluation on his own before they come here, but works with a small team on our cases, doing all this evaluation. And Joe is doing the presentation tonight. He's a CDT. He's worked with the Road Dental Lab for more than 35 years. He's our technical director, and he started at case number 1 in 2004 with guided surgery, and case number 1, Chrome Guided Smile, more than 3 years ago. And so he's going to give this presentation tonight, and I think it'll be, as you say, delightful. Mm-hmm. So I'll let Joe take it away.
Okay, thank you. Case number 1, by the way, was in 2004. Yeah, so this has been going on for quite a while. So welcome, everybody. I'm glad you're here. I think that this presentation is pretty much, in my opinion, the heart of the system. Because without records, without analysis, without correct vertical dimensions, without a lot of thought, these cases don't go as well as they can. So, this is full arch case analysis, and actually whether it's crown and bridge kinds of cases or hybrids or guided smile, it's all the same. And we are getting into what we call Chrome Natural. It's beta right now, which is FP1 type restorations that is used with the Chrome system. But it's not just about teeth. And as we go through this, you'll see, we think of it as treating the entire patient, whether it be with their self-esteem or their looks, or everything about the person that makes them feel good about themselves. And these cases do that. This is designed to provide the best path for optimum results for these cases. So everything that you see here in this presentation should be, or you should try to accomplish before you send anything to the laboratory to begin fabrication. Otherwise, we have to go through this with case after case, and it slows the process down, and that's the one enemy we have is time. So the more that we have that's accurate and ready, the easier the cases go in the lab and in the surgery. So we'll start out with what you need to send us, and I think Alan mentioned that he did a records program for you, and this is a little bit about records, but it all ties into the final result for us. So obviously we're going to need master models or impressions, capturing all borders and anatomy necessary for full denture construction. Why do I say that? Because sometimes you're going to request spare dentures just in case you don't get enough torque to load a case and the patient has to leave with teeth. So if you think you want spare dentures, I would suggest analog models unless you're very, very good at capturing everything we need, peripheral rolls, hamular notches, posterior soft palate on the upper, enough that we can make a successful denture in case we can't load the case. Confirm bites and VDO. We need a photo series. We're going to obviously need a shade. And my opinion at this point is don't schedule a surgery day yet. You can talk about general timing with the patient, but I advise waiting until we do the online meeting to schedule a surgery date. So the first appointment for you is the consultation. I would call it the consultation appointment. It's to determine a treatment plan. It's to review the materials options that you have with the patients. Whether you decide that or you discuss that with them, that's your call. You want to confirm the fees with the patient, and again, don't set up a surgery date at this meeting. So I mentioned talking about the materials, and so I'm going to go through the different materials that we can use here very quickly, but since this is being recorded, you'll be able to refer back to it. Ultra Nano Trilor, Crystal Ultra Hybrid is one of the strongest, most functional and aesthetic nanoceramics available. And added to Trilor, a Trilor frame, it's a very strong resin that provides rigidity while still having flex to absorb strength. So that's important. Tensile strength is sometimes an advantage to us. Okay. Nanoceramic Crystal Ultra. This is just the another description of it. Shock absorbent, feels like real teeth, aesthetic nanoceramic. So, I think one of the key things, it looks and feels like real teeth. It has a nice, when patients bite, they don't hear clicking like they might with zirconia. And that's one of the reasons I get that question a lot. If I get zirconia, is the patient going to hear their teeth click when they're talking? So that's something to think about as when you decide on what materials you want. Trilor is a high-performance technopolymer matrix, and this is just an explanation of its scientific properties. Trilor exhibits natural flex and load parameters, so making it the ideal replacement for unforgiving metal and zirconia framework. So, that comes into play too when you decide. You have bruxers, or you have people that might be really tough on a case. This might not be the stuff to use. You might want to use zirconia for something like that. Okay. Anybody have questions? Were we taking questions, Alan? At the end, we can have questions. Okay. All right. Zirconia, which we make quite a few of the zirconia hybrids here, a lot. I mean, we're loaded with them. It's strong. It doesn't break, and I'll describe what I mean by it doesn't break. It doesn't break. It doesn't chip. When you put this in, it's in unless something very traumatic happens. I suppose it can break. Now, the one thing about this material is that it doesn't have tensile strength. So when I mention the fact that it doesn't break, that's like in occlusion and eating and that sort of things. But it's a strong material that resists chipping and breakage, but has no tensile strength. So the framework must be totally passive to avoid fracture. We have had some of that. And so when these are finished, if they are not totally passive, there's a good chance somewhere down the line that that patient's going to feel a little tink in their mouth, and that's the fracture that happens. And these, we can't fix these. They have to be remade. So passivity is the key with all of these things, but especially with zirconia. Titanium frame with ultra nano crystal. We can make titanium standard frameworks, and we can mill the monolithic tooth section that we bond on to the treated titanium frame. And that provides a very strong frame with the advantage of monolithic teeth overlay, which, they're highly resistant to breakage. You won't have that denture tooth pop-off syndrome that these things have if you use just an acrylic wrap with denture teeth. So this one is the original Dr. Brannemark design with titanium framework, acrylic wrapped with denture teeth. And this design was a workhorse for years and years. Now we're doing less and less of this because the one downfall to it is, the materials aren't as strong as patients' bites sometimes, and debonding of the teeth can happen and does happen sometimes, and that's just a repair that you have to do. So those are the options that we provide. Any of them that you want is what you can prescribe for your patient. So restorative space parameters. This is really important. It's something that we fight with all the time when we're restoring cases. The FP1 zirconia crown and bridge case, which is what we call our chrome natural at this point, is it's crown and bridge. I mean, you're not going to see pink porcelain on it. It's going to look like a standard crown and bridge case. And we call this our chrome natural at this point. And we like to have 10 millimeters minimum space for restorative purposes with this kind of a case. Okay, now sometimes on these naturals, we do have to do slight bone reduction. Usually with FP1s, we don't. FB2 is a zirconia crown and bridge case where we may have to add porcelain in areas of the case because of resorption or whatever that, what happens. This is also, we designed this as a chrome natural case, but in this particular instance, we probably might need to have 12 millimeters of space because if we're going to be using pink porcelain, that means there's gaps and we have to have support for that. The FP3 is a standard hybrid, the GuidedSMILE. We need a minimum of 13 millimeters of space for this. And I'm going to expound on the 13 millimeters because there's an asterisk next to that when we get into certain cases that I'll show you here later in the presentation. So pre-planning workup. What we do, what you're looking at on this presentation is exactly what we do every day with every case when it comes in. We look for everything that we ask for you, like models, records, photos, things that help you determine where the starting point should be. So the facial analysis is to make sure vertical dimension is correct. Okay. For instance, and this doesn't happen a lot. It happens sometimes. Doctors are a little hesitant to use it because of time, but if we're opening a bite more than 3 millimeters, we recommend an orthotic for the patient to wear. And how long the patient should wear it is up to you. If they wear it long enough that you're happy that they're comfortable, then we can make the prosthetic at that vertical dimension, and that prosthetic then turns into the orthotic that you can still adjust as the patient is going through their healing phase. Okay, we need a good centric, aesthetic analysis, tooth position, all the things we look for if we were to make a standard denture case. We have a list. It's called the Aesthetic and Functional Checklist. We need you to fill that out. The doctor should fill it out in full. If they just go down the list step by step by step and fill it out, we will have pretty much everything we need as far as information is concerned. Okay, so now if orthotic therapy is indicated and you decide that you want your patient to go through with that, then you're going to have to, you'll give them a time frame. And this case can't go any further until you're happy that their vertical and centric is confirmed and resolved, and then we can go ahead and start the GuidedSMILE process. This is what the form looks like. I think it's on our website. You can download it. And everybody that, one of your customers or referrals out there that get a case like this should get in the habit of filling this out for you. I don't know what you have in Europe, but we have a magic bite button here that we thought the computer could help us with. It didn't work, so I say that, I joke about it, but we are constantly addressing bite relationships in our case analysis. And I'll show you what we get here. And I'm not showing that's to, complain or about dentistry or whatever, but this is the facts. This is what we get and what we deal with. And for some reason, I just have it in the back of my mind that because a lot of this stuff comes in digitally, that it's going to be okay. We can take bites where on other cases we would have bite rims and teeth setups, that sort of thing. But it's still dentistry, and we still have to go by the rules of prosthetics. So what do we mean by confirmed bites in aesthetics? A confirmed bite is one where there's positive centric stops and bites that doctors have verified and confirmed with wax tryins, printed tryins, or an orthotic to confirm vertical dimension and centric. And as I said, aesthetic information earlier, I went over that, all the things we need to make sure that the patient, is happy with the teeth they get and the position that they're in. So when we get a case in and we get a bite, a digital bite, for instance, the bite scan, the printed bite scan is on the right. That's what we receive. You can see how much of a class 2 a deep class 2 case this is. And you can see on the left screen the opening that we proposed for the restoration, and we sent that along to the restoring doctor or the surgeon, whichever it was, and got their permission to either open or keep it where it is. We don't dictate what to do. We have these red flags that we see that we bring to the restoring doctor's attention, and and they will make the decision on how they want us to proceed. However, in some cases, especially on single arches, if we have a deep class 2 bite and we can't do anything with the vertical, sometimes the plane of occlusion can never be correct. So, secondly, these cases aren't really a kind of a case that you want to leave in a deep class 2. So anything we can do to avoid this situation that's within the parameters of function and aesthetics, I think that we'll bring that to your attention, or you'll bring it to your customer's attention for them to make decisions on. Photographs. This is one of our best tools. And I'm going to show you that there's 7 photographs that we must have here. If we don't have all of these kinds of photographs, they can turn into phone calls for more information. So, we need what you've read here, some non-retracted and some retracted pictures. The non-retracted are of the patient's smiles, and the retracted are of the patient's bites. So the first one we want is repose, so that we can see incisal-edge positions at rest. Natural smile. We want an exaggerated smile that shows any gingival excess that might need corrected, and I have a formula for this process you'll see later. And a profile picture with the ears showing and the lips and teeth closed and the lips or the teeth in occlusion and the lips closed, because in some cases we can use the Frankfort horizontal mandibular plane angle as a guide for correct vertical dimension, and there's some interesting things about that. I have a couple slides on it I'll show you. Now these 3 pictures are the ones we use retracted, and we need a facial frontal picture of the patient in occlusion, and we need a left side picture with the patient in occlusion and a right side, so that if you're sending digital bites, we can compare those bites to these pictures and see if we see any discrepancies or anything you need to know about to correct that. So vertical dimension analysis, which is one of the things we attack quite often because of the nature of these cases. Many of these cases are just blown out dentitions, worn teeth, teeth gone, teeth bites that have closed because there's no opposing teeth, all the things that you know about. So if we have cases without positive centric stops, we, again, going back to just basic dentistry, it's best to get bite rims and a tooth tryin made, or a printed tryins made for those cases, so that you can confirm the bite in vertical. And again, as I mentioned earlier, anything over 3 millimeter opening, you can choose to have an orthotic to test the bite, and you'll know your patient. Some patients you might think they need it, others you'll be okay with. So you have to decide that yourselves. But in some of these cases, we've had some pretty extreme openings with good success, only because the patient's upper dentition is so worn that they almost touch the gums of the lower on a really extreme case. So that has to be rebuilt for function and aesthetics. Okay, so the tools we use here to help determine VDO are the Shinbashi, which I'll explain, the fold-to-fold measurement, facial rule of thirds, phonetic evaluations, and the Frankfort horizontal mandibular plane angle. We use that one the least. The two that we use the most are the Shinbashi and fold-to-fold measurements. The phonetic evaluation, obviously, you'll do that chairside in your analysis. So the Shinbashi measurement is something that I learned in my LVI training years ago, and with teeth in occlusion, measure from the CEJ of an upper central to the CEJ of a lower central. And the average for people is 17 to 21 millimeters. When the measurement is less than 17, the path of closure causes unnecessary muscle activity, puts teeth and jaw and muscles in conflict, and can create jaw pain. And there is literature that even they're finding that it's a destructive dentition, and they can actually start destroying their teeth or implants that are in, causing them to be lost. So these, if you restore less than this parameter, the suggestion is to over-engineer your case, meaning more implants. Okay, so this is the Shinbashi. If you'll see this case on the left is this is a red flag. When we see that, we don't even have to measure it. The only reason we would measure it is to take us up to 17 and see how the plane of occlusion and how that would affect aesthetics according to the photographs. So this kind of bite is very, very common with what we do. So the middle picture, the one I just talked about was on the left. The middle picture shows a Shinbashi that's 16. So when they're 16, that's borderline. So you'll do some phonetic evaluations. You'll look at their face. Do they look like they're closed? Do they have this closed look in their cheeks? The frown that people get in the corner of their lips, that sort of thing. And you can decide if you want to use this that measurement. But it is 1 millimeter less than normal. But those measurements are. You have to use some good judgment when you decide to use these measurements. Now, the one on the far right is normal. That's 18.5. Falls right into the normal range, and we wouldn't do anything with that vertical unless the doctor said that he wanted to do it for whatever reason clinically he chooses. Okay. The fold-to-fold measurement is one, and this is where I go back to models. We can't make this measurement unless we can see all the peripheral borders. And the fold-to-fold measurement is taken from in the lateral area, from the fold in the lateral of the lower to the fold in the lateral of the upper, and that range is 35 to 38. And just about every time, this fold-to-fold measurement confirms a Shinbashi measurement. So we'd like to use more than one just to make sure we're correct about our analysis, because when you have cases with altered passive eruption where all the teeth are short and worn down, that fold-to-fold measurement might be normal and the Shinbashi might be 12. So that's something where you really have to evaluate whether opening is necessary or that's just from abrasion as the teeth wear. Okay. So the Frankfort horizontal measurement is if we get readings between 20 and 30 degrees on this angle, then we're normal. Anything below 20 is not enough. Anything above 30 is too much. So we know how to measure that and look at it, and that's just another tool we use if we have to help us determine that. So we look at whenever we have pictures for this, we look at this measurement also. So the lowmandibular plane angle, I think this is an important picture because we're putting a lot of implants in people's mouths, and they're used to bad bites, incorrect verticals, things of that nature. So if you get into the high angle, there's a decreased biting force. And when you get into the low angles, the biting force is stronger. And the increased biting force on the low angle patients causes more stress to the residual ridge. So basically this is telling you that if you work with a low angle, that over-engineering the case is going to be something you want to really think about. Okay, so this is just a little sample of pictures that we get. Some of them, a couple of them weren't from the cases that we did. This one on the top left, we did this case. And this photograph, along with measurements, confirmed that obviously you can see in her cheeks and her lips that her vertical was collapsed a little bit. Same thing with this gentleman here in these pictures. The crow's feet in the corner of his lips, his chin right in this area, you see that circle. This, you can see a difference. This patient wasn't one of ours. This one I got off the internet, but it shows the closed position and what her face and cheeks look like. This lady's picture looks just like this gentleman's picture here in the center, and this is the result of opening. Okay, this patient we did the case on. I don't have any afters for her, but this is another reason we would question vertical dimension, because she has no centric stops that I can see in this picture that would help us determine where her bite is. So this would require bite rims, teeth tryins, and all that stuff workup before we start. In the altered passive eruption case, this is where you really have to look at photos and fold measurements, and you really, your good judgment will help you decide on where to use your vertical dimension with this case. If the patient smiles and their tooth display is good, upper and lower, that you would probably leave it like that and make sure there's enough bone to do the case. This we see quite often. I mentioned this kind of a case a little earlier where the lower teeth are just crushing right into the upper ridge. These teeth have probably erupted, but at the same time, we know just because of the lengths of teeth the teeth have, that this has to be closed. So this is one where, we would probably suggest an orthotic. This is another red flag. You can't even see the lower dentition with this patient's mouth closed, the teeth in occlusion. Okay. Pragmatic bites, no posterior stops. So this is another one. Tooth tryin would be recommended for this. And, it sounds like we're asking for a lot and a lot of analysis, but having been to hundreds and hundreds of these surgeries, anytime you get one of these cases back and you have to grind a bite in, it's not a very fun part of the process. And that's what we're trying to avoid here is bites that aren't correct, and just a lot of time spent when you're in surgery, when the patient has to stay under and those sort of things, and they're in the chair longer. So it's just to help make the case the best it can be. Here's another red flag. This gentleman's lower canines, teeth are touching his upper lip when he smiles, so obviously he's got a bite issue. Maxillary excess hyperplasia. This is very interesting problem. Again, this is the one thing I mentioned that I have a formula for that I'm going to go through with you. So again, all these things that I'm showing you, we look for when we're doing these cases. This one, no posterior stops. This one, we have one tooth in occlusion. This is the same case, just from a side view. So these would, we would recommend tryins, opening bites, whatever. I mean, it's just things for you to look for when you have your patient there to make sure we're correct. Deep class 2s, no centric stops. So, if you open the teeth tryin or an orthotic, or we can make a JC tryin that acts as both. Same thing here, no centric stops. This was one where we did an orthotic. The doctor did do one. This is it right here. We put one in both arches, and the patient wore it, and we came to a resolution with the jaw, and all this came back. We scanned that orthotic on the models in place, and that was the bite we worked with in the software. So the way we do it on something like this is we see a case like this, we open it, we take pictures, we send the pictures to the customer, to the doctor, and see if he approves of that opening. And if he does, we continue, or he'll give us his feedback. But we have a lot of good cooperation with this, and not very many issues when we do it that I've heard of, since we've been presenting this work like this. And another deep class 2 bite. So, all right, some reestablished VDOs these are just results. This is where this lady started, and you can see in her face the difference. But this is the result of good records and vertical dimension analysis. So how do we send this information if you use orthotics or you use the bites, how do you send it? Digitally versus analog. So obviously, on digitally or analog, you need to send models back along with the actual orthotic that you've used with a bite, and that's what we're going to scan into the computer to complete the case with. Digitally, we just need you to do a bite scan, just as you see here with the orthotic in place, okay, because you might want the patient to keep wearing it because they're comfortable with it. So we just need a bite scan that you see here, and then we need to have the upper and lower scan separately, bite scan and the upper and lower arches scan separately, and sent to us via the internet, and we can work with that in our software. This is a case of the maxillary hyperplasia that I talked about. This case we did, I don't know, 2 years ago, probably now. And you can see what this patient looked like. And what we have to do here, we have to take measurements. So at the exaggerated smile, we need to have a measurement from the incisal edge of the central to the lip line. So, and what we're doing this for, all of these measurements, if you look down on the bottom, the bottom right here, you'll see what we're trying to avoid. This is a transition line failure. And the transition line failure is most of the time lack of proper planning, lack of enough bone reduction to help eliminate this problem. Could even be a vertical dimension issue. So anything like that can cause something like this to happen. So we call it our gummy smile formula. We take the measurement from the incisal edge, and if it, for instance, if the measurement is 10 from the incisal edge to the upper lip at an exaggerated smile, we need to add 4 millimeters to that, and that is where that 14 millimeter number is where we would put the top of the implant. And at that point, we then judge restorative space. If from the top of the implant to the exit point of the screw in the prosthesis is less than 15 millimeters, then we need to push this implant further down so that we can get our 15 millimeters of restorative space. This has worked very well for us. And it saves a lot of guesswork. we can actually, mathematically do this. We actually now have an algebraic formula that we can do it with as long as we have a photo, so that you don't have to have the patient back to measure it with. So this is a formula we use when we have these kind of cases. Now, what this tells us is this patient going to be able to get a hybrid, or do we have to go to an FP1 crown and bridge type case with this to solve the problem? Because if by creating the restorative space we need, we run out of room for an implant because there's not enough bone depth, then obviously we can't do the kind of restoration that we intended to do at first, which is the hybrid. And we have to resort to working this out in crown and bridge, which we can, which means that the implant is going to go more coronally, and we then just have to figure out the gum line from there, because it's a different dynamic. Patients can smile with crown and bridge and show their gums a little bit, and it's not an issue. Okay, so this is actually the actual result of this patient's case with the maxillary excess hyperplasia. And great result. I mean, you can see her smile on the left, how far her lips are apart, and you can see her smile on the right. They're not as far apart, which just gives her a better look. So it changes a little, it's a little plastic surgery almost. So the formula works. This is another case. This ended up being a crown and bridge case that we use these measurements on, and a nice result there. Once you have done all this analysis, filled out the information we need, you're happy with what you send us, then the guided smile process begins. Now, up front, this might take you a little more time, but ultimately, it's going to save you time and agony as far as, case after case after case is concerned. So I think that is the last slide. And thank you for your attention. And if you have any questions, I'll be happy to entertain.
Yes, thank you very much, Joe. That's very interesting. Unless the records are correct, they're not going to get the result they want. The patient's not going to get the result they want, and the case won't go ahead as planned. So I don't think you can reiterate this stuff enough to people. I'm still absolutely amazed that 7 out of 10 cases go back. And the first question that came in is, what are the top 3 reasons a case is sent back?
Well, when you say sent back, it doesn't get sent back. We just ask for more information. Yeah. Right. In other words, we stop the case, and the top ones are bite relationships, bites, vertical dimension, as you saw in all those deep class 2 cases, that sort of thing.
Yeah.
Photographs. If we don't have smile photographs, we don't know what to do with the teeth, because all we have to go by is what they have on models. Yes. And smile photographs show us lip line, it shows us tooth display, it shows us cants in the horizontal plane, and again, it shows us that this, the faces that you saw that were all distorted because their vertical was too close. That's what those are probably, the top 3 things, along with, I might add too, just data problems, bad scans, trying to send data to us, and we get it in the wrong format, things like that, which are, that's learnable, and I get it. It's pretty hard stuff for an office that just starts doing it, and once the office learns it, then then they have it. One suggestion I would have to give your customers that you're going to be working with is that the doctor of the office, whoever the office is, needs to know that scanner backwards and forward.
Yeah.
Because if whoever you have using it leaves for some reason, you don't know how to train. And you can have the companies come in and train. They give you some training, but it's not always enough. And they're not there every day to see the problems. So that I would suggest that too. But those are the main reasons we have issues. Sometimes we have issues because of timing. 99.9% of the time, we meet the times that the doctors ask for us, because they'll schedule surgeries before they start this. Then we run into the problems of getting what we need and things like that. That just very stressful.
Yeah. Get it. The next question is, what is the most popular materials that you're sending out for the final bridge work? You obviously covered a few at the start, but what is the most popular, and what determines that?
Zirconia. For FP1 cases, it's zirconia, because we're doing, large bridges. Porcelain to metal, I don't think we've ever done a case like that.
All right.
Porcelain to metal with any of these. So it's zirconia, and it's the ultra nano Trilor.
Okay.
Now, with the design we're using on our titanium frames with ultra, they work out pretty well. So, Trilor, heavy bruxers, things like that. These patients have these heavy bruxing bites. I don't know if I'd use ultra nano on that. I would probably go to a titanium ultra case and or a zirconia.
Yeah. And are you doing many removable cases?
No, actually, I shouldn't say that. We're in a beta with some removable locator type cases that is used in conjunction with the chrome.
Yeah.
So, but we don't have very many cases of those out there, and we can't even make any kind of a judgment on it at this point. Okay. But other removable cases, you're talking about with chrome guided or any kind of guided?
And with chrome guided, it was a question that came up earlier on today. One of the guys out on the road, which was, could this particular customer he liked the idea of doing it guided. He liked the idea of his implant placement, but he also quite liked the idea of providing removable provisional to the patient rather than a fixed provisional.
Well, that's everything I've ever learned is that's contraindicated.
Yeah, absolutely. I'm just
because you're going to be putting stress on the implants every time you try to take it in and take it out.
Yeah.
So I would answer that with a no.
Yeah. Okay. Yeah, it is something that's done here, mind you. Yeah. Do you?
Well, go ahead.
Go on ahead, Joe. Go on ahead.
No, I mean, people have tried it, and we couldn't stand behind anything like that. Just couldn't do it.
That's fair enough.
James.
Yeah.
James. Just to add on to that, add on to what Joe said, it's there's a high demand out there for a more affordable, removable prosthetic, and we know that, we respect that. There's no getting around that, and for that reason, we're developing. It's a product that's on beta, and it's only with it's a limited beta group of doctors, but it's something that we're forecasting is going to be really popular, and that's this. We call it a locator guide.
Yeah.
And it's essentially a denture with a surgical guide in it, and then you just bond teeth on top of it during surgery. So we're going to. It's going to be a couple of months or a few months before we roll it out, but we'll roll it out to you, James, for sure, and you'll be able to order it.
Yeah. Okay.
Yeah. Okay.
Okay. It's interesting, the impression question, because this has come up a couple of times. Obviously, you've stated again, Joe, and you've reiterated what Alan has said a few times, which is the importance of capturing the borders and soft tissue in your impressions. With that in mind, the question is, do you prefer conventional impressions, which are then digitized?
I would prefer conventional digitized impressions if you want spare dentures. Yes.
Okay.
Yeah, because the scans that we've seen, none of them capture everything you need for a successful denture. And the doctors will say, well, go ahead and make it, I'll reline it. But I just can't see how that works all the time. It's just not the right thing to do. Let me make a little, another comment on that. You asked me what some of our problems are. That might not be our top one, but anytime people want spared dentures, most of the time we don't have models that we can use for spared dentures. And that's, that's the digital thing. That's, that's really that's, people just can't do it with digital. There's some things you just can't use technology for, and this is one of them. Yeah. Okay.
At the very start of the presentation, you mentioned passivity of fit for the zirconia bridges.
Mm-hmm.
The question that's come in is, how do you confirm passivity of fit?
Okay. There's a thing called an iJig that we use. Okay. And basically it is a printed tryin that is sectioned, and it has a plastic suck down on it that these sections fit into. Mm-hmm. And you're able to take that to the mouth and screw it in, align screw it in, take the plastic suck down off, align the sections together, and connect them.
Okay.
Because what that does is then each section is assigned to one implant, and when you put it all together, that becomes confirmed. It's a bite jig, basically, is what it is.
Yeah.
And it does a few things with us, because when you send that back, you'll send it back with an impression of the tissue under it. You equilibrate the bite. You'll do everything you would do for any kind of a tryin. Critical parts of this process is that the prosthetic process, that is to have this thing fit passively. We can send you information on that so you can pass it out to your salespeople so that they can help with that too.
James?
Yeah.
Let me add that I know the protocol that you've been espousing, which we agree, and that's the using the rapid appliance.
Yeah.
And then the rapid appliance, the duplicate pickup, is the method for making a master cast. But still, even with the predictability of that pickup at the day of surgery, it still would be important when the time comes to restore 5 months down the road to do a one screw test, or to take x-rays, or to passively seat it, hand tighten with screws. And, because that is a plastic appliance and it could still bend a little bit if you really tried to tighten down the part. So that has to be passive. It can be sectioned, picked up, and so forth. That's how you also ensure passivity. Okay.
Yeah.
No, that's okay, because it is a question that's been raised a few times, because what I suppose most of the guys over here do is they do a separate passivity check. So they'll do a pickup basically, pre-doing their final bridge. And it's really just looking at the workflow of the rapid appliance and how people would feel comfortable ensuring that.
Yeah. The rapid is the key for prosthetics. For prosthetic success, the rapid is the key. And I will give you one. I'll give you one suggestion for the rapid. And are you there?
Yeah. Oh, I'm listening. Yeah.
Yeah. When you put the rapids in, you have to keep in mind that the patient's been wearing a provisional that you've done adjustments on, occlusal adjustments probably. So when you put the rapids in, re-equilibrate them into a comfortable bite.
Yeah.
Because if you just send us rapids with a bite, unless you equilibrate them, you'll be changing vertical dimension, and you might be you'll be causing more tryins than you need to have.
Yeah. Well, we have been teaching that so far, that when the rapid goes back in, that you must re-equilibrate on the rapid itself.
Exactly.
Yeah. The question is, how do you give the information of a final occlusion? So how do you get that back to you?
What do you mean, the final occlusion?
Yeah. So
at which phase? The final appliance, or?
The question is the final. Yeah, the final. He's talking about the final bridge. So obviously the stage between the rapid and the final restoration.
When you get your printed tryin back, the doctor's going to try it in.
Well, explain what a printed tryin is.
Okay, and a printed tryin is simply we design, instead of setting teeth in wax, we design teeth in a computer that the doctors can screw in, and they're white, and it's going to be pretty much a replica of their final appliance. So when you go through that, when that is at that appointment, that's where you put it in. They have to equilibrate that, okay? Even if it's just a little bit, it's easy to equilibrate. You don't have to worry about wax melting because this is all resin. They can equilibrate and give us a bite, and that's really all we need.
Yeah.
But equilibration at these steps is really important. We've had cases come back from printed tryins where the bite's really way off for some reason, and the doctor or an assistant, I don't know which, takes a bite and the molars are hitting, and that's it, and there's 5 millimeters of space in the anterior. So at that point, we don't know. I mean, obviously we need to grind it down till the anteriors of the upper come close to the lowers, but it's always a question. We always have to call. I mean, we have this opening. Now our vertical dimension's different. What do you want us to do? So equilibration until you get it right where you want it is a key.
If you have modified the provisional over a period of time, so really what I think the answer here is that you modify the rapid at the time the patient is in. The rapid then goes back to you, so that's an exact replica of what you want in the upper jaw, a new lower model, and a bite, and that's all you need.
Yeah. Well, yeah, exactly. Well, your rapid is gonna is going to have analogs in it, and from that rapid we're going to make, you'll do a tryin, and so there's two things you can do with the rapid. When you have the rapid in for that appointment, and there's space under it, you can equilibrate it, you can get the bite right, and then you can inject your impression material under in the intaglio area and around the borders, and send that, and that gives us the new model, the tissue position, and the bite.
Yeah.
Okay.
Yeah, that's the last question I have. So thank you very much, Joe. That was very useful. This will obviously be recorded and will go on YouTube, and we'll be sending it out. But as I say, I think it's a very, very important piece of information, this presentation. So thank you for putting it together.
Well, it's my pleasure. Thank you for joining.